So these are the anti-resorptives that essentially work by inhibiting osteoclast activity. So I'll start with the bisphosphonates. These are the most well-known and most used osteoporosis drugs and have the longest history of use as osteoporosis medication, apart from possibly estrogen derivatives. As the name suggests, bisphosphonates contain two phosphates in their molecule, which makes them bind to bone via adsorption to hydroxyapatite crystals. And then they have different side chains, which are associated with variation in potency and effectiveness at different sites. They are highly specific for bone, and they even get incorporated into the bone, which gives them an impressively long half-life, possibly persisting for years even in the body. When osteoclasts release them from the bone during resorption, the molecule is released and has toxic inhibitory effects on the osteoclast. This thus inhibits resorption and improves bone mineral density. Alendronic acid, also known as alendronate, is the gold standard for bisphosphonates and indeed osteoporosis treatment. And there's residronate, because these are the cheapest, especially alendronic acid, and are taken as tablets. In addition, alendronic acid is quite effective for how much it costs and has been proven to reduce the risk of vertebral and hip fractures, and is typically first line for patients with mild to moderate osteoporosis, and is pretty much recommended first line in all the international guidelines for osteoporosis. Residronate is slightly less effective at reducing hip fracture risk, so might be reserved for patients who are struggling with alendronic acid for whatever reason. To see whether a osteoporosis drug therapy is working or not, apart from using DEXA scans, you can also measure bone turnover markers. And these are molecules which are byproducts of bone formation or resorption. For example, we have CTX and NTX, which are collagen fragments, which are released during bone resorption. And this chart shows levels of bone turnover markers have gone down with the use of alendronic acid, indicating bone resorption has been reduced and that the treatment was working and the patient is compliant. So actually it also shows that bone formation is also reduced by alendronic acid. This is because reducing osteoclast activity reduce requirement for osteoblast activity, and shows how osteoblast and osteoclast activities are coupled together. Nevertheless, overall there is reduced bone remodeling, which does improve bone mineral density, at least for the initial first few years. This also shows how bone mineral density increasing capabilities of anti-resorptives is capped, due to the fact that they reduce osteoblast activity at the same time. The oral bisphosphonates, that is alendronic acid and residronate, require very specific instructions for taking them for two reasons. The first is that they have very poor bioavailability. This is less than 1%, and the presence of any food and medication, especially those containing minerals, including calcium, iron, and magnesium, reduces the bioavailability even further. Bisphosphonates bind to minerals such as calcium, which makes them less bioavailable, and this is a key point to note, as calcium is a vital supplement that osteoporosis patients need to take along with the osteoporosis medication. So because of this, alendronic acid and residronate needs to be taken on an as empty a stomach as possible, in other words, a fasted stomach. Hence, they should be taken first thing in the morning. After having slept overnight, you have an overnight fasted stomach, and at least 30 to 60 minutes before breakfast. So 60 minutes would be better, but typically 30 minutes is what's put in the instructions, as this is more practical for most people than 60 minutes. So this includes any medication, but as I said before, especially minerals, including calcium. calcium should really ideally be taken something like 4 hours later, but there's variation between guidelines on what the gap between oral bisphosphonates and calcium are, so you can just refer to your local guidelines. The second reason is that bisphosphonates directly irritate the gastrointestinal mucosa and have been known to adhere to the mucosa in the esophagus, causing esophagitis and gastritis. And for this reason, they need to be taken in an upright position with a full glass of water. And once taken, the patient needs to stay upright for a minimum of 30 minutes. And then ideally, breakfast should be taken to make sure the tablet really transits properly through the esophagus and stomach. So here are the instructions again all together. And this is well known to most pharmacists. It seems to be a lot to begin with, but actually it's pretty doable unless you have difficulties with swallowing or being upright, something like that. Plus, alendronic acid and residronate only need to be taken once a week. Actually, residronate can also be taken once a month, which helps. But you should know that even if you follow these instructions religiously, even if your stomach is in a 100% fasted state and you don't have breakfast until 60 minutes later and you take your calcium tablets hours later in the day, the absolute maximum bioavailability you will ever get is 1% each time. And actually, it's slightly less than 1%. It does help that bisphosphonates accumulate in the bone, but you can now understand why oral bisphosphonates may not be suitable for everybody, as any non-compliance will render bisphosphonates ineffective, and poor compliance with oral bisphosphonates is quite a big problem if you are serious about preventing fractures. So then we come to IV bisphosphonates. So there is ibandronate and zoledronate, or zoledronic acid. So these are more expensive and tend to be reserved for patients who aren't able to comply with the administration requirements for oral bisphosphonates, or patients who have GI problems such as gastritis or swallowing problems, or for patients with more advanced osteoporosis who require more intensive bisphosphonate therapy. So not only are they IV so that you can bypass the whole GI bioavailability and irritation issues, they can be given even less frequently than the oral bisphosphonates. So zoledronic acid is a third-generation bisphosphonate and only needs once yearly IV infusion administration. So needless to say, once yearly IV dosage will bypass issues with compliance, which is one of the main issues with oral bisphosphonates. You won't see ibandronate or ibandronic acid as much, as it doesn't have effectiveness on reducing hip fractures. Zoledronic acid has been shown to have significantly higher potency for reducing vertebral fractures, although not necessarily higher on the other sites. Still, just eliminating the compliance issue alone is guaranteed to improve efficacy with IV zoledronate. And it has been shown that administration of zoledronic acid to patients who have a hip fracture, as well as reducing further fracture risk, is associated with reduced mortality. And the UK NOGG 2021 guidelines uses zoledronic acid first line in hip fracture patients. In addition to having a once yearly dosage schedule, a recent study has shown that one 5 milligram dose of zoledronic acid can even prevent bone loss for a decade, indicating even less frequent doses of zoledronic acid may be effective, potentially enabling reduced effective treatment costs. Just note that this is not current standard practice. I'm just speculating that this might be something that could happen sometime in the future. So other than the compliance and GI issues for oral bisphosphonates, bisphosphonates generally are well tolerated and definitely help with improving bone mineral density and reducing fracture risk for people with mild to moderate osteoporosis. They do, however, have two very rare but infamous adverse effects, which are osteonecrosis of the jaw and atypical fracture. Atypical fracture typically occurs in the femur, unlike the neck of the femur for atypical osteoporotic fracture. And osteonecrosis of the jaw, or ONJ, is a rare, serious condition that causes bone cells in your jawbone to die and jawbone to poke out through an opening in your gums. And both are probably related to prolonged disturbance of bone homeostasis by the action of bisphosphonates on osteoclasts, but are very rare. And for sure, the proven benefits of bisphosphonates in reducing fracture outweighs the risks of getting atypical fracture and ONJ. So the risk of atypical fracture and ONJ starts off as very low to begin with and increases incrementally with each additional year you are on a bisphosphonate. But as soon as you stop the bisphosphonate treatment, the risk rapidly drops down to baseline. And at the same time, the effects of bisphosphonates after 5 years of therapy actually persists for years after stopping. So there is a clever strategy to use this to further minimize the low risk of atypical fractures and ONJ, and that is the bisphosphonate drug holiday. So depending on the patient's bone mineral density, how long they've been taking bisphosphonate, and which bisphosphonate they have been on, after 3 to 5 years of bisphosphonate therapy, they can have a drug holiday of up to 3 years. So during this time, their bone markers and bone mineral density should ideally be monitored so that osteoporosis therapy can be restarted when clinically indicated to do so. And then when you restart the bisphosphonate therapy again, the atypical fracture and ONJ risk is effectively reset back to baseline. There are some suggested guidelines for how long a patient should be on a bisphosphonate before taking a drug holiday, and how long the holiday should be for, with variations between different bisphosphonates, but each patient needs to be assessed individually and their plan tailored accordingly. For example, if the patient is on an oral bisphosphonates, whether their doctor thinks they're ready to go on a drug holiday may depend on how compliant they've been with the medication, but generally roughly 5 years is required. And it is generally viewed that patients on zoledronic acid can go on a drug holiday after 3 years. And as mentioned before, there isn't a standard set duration for the drug holiday itself. It depends on how well the bisphosphonate effects persist, which can vary from person to person, but generally it can be between 1 to 3 years. And patients with severe osteoporosis might be advised to not have a holiday and continue taking the bisphosphonate for more than 5 years. That's it for this video. Check out the other videos in my osteoporosis video series.